Good afternoon, everybody. Today we shall discuss about radiology and imaging in obstetrics and gynecology. So, where we have to seek the help of the radio diagnostic people, and in this mainly the ultrasound in obstetric practice is an important because now besides clinical examination, the ultrasound is the next immediate investigation which is required for obstetric practice. The ultrasound technique uses very high frequency sound waves between 3.5 and 7 megahertz. So this is inaudible ultrasound. So ultrasound scanning is currently considered to be a safe, non-invasive, without irradiation, without radiation to the fetus and the mother, and accurate and cost-effective investigation in the fetus. There are two types of mainly transabdominal and transvaginal. Transabdominal ultrasound has to be done to visualize the pelvic organs with full bladder where to examine the patient. In transvaginal ultrasound, we have to empty the patient bowel, empty the bladder, and we have to do transvaginal ultrasound. So in transabdominal, you must do with full bladder, and in transvaginal, we have to examine the patient with empty bladder. So these are the abdominal probes, which varies in frequency from 3.5 megahertz to 7 megahertz. These are all the probes which use for abdominal scan, and also the small parts like thyroid, testis, where the resolutions are high and the penetration is also less. These are the transvaginal probes. These will be of different angles, 90 degrees, 120 degrees, 60 degrees. According to the radiologist fancy, they use whichever angle is convenient to them. Advantage of ultrasound are diagnosis and confirmation of viability of early pregnancy. By this, we can do ultrasound, and the gestation sac can be visualized from as early as 4 to 5 weeks of gestation, and the yolk sac at about 5 weeks. So we can diagnose pregnancy as early as 5 weeks of gestation. The embryo can be observed and measured at 5 to 6 weeks of gestation. A visible heartbeat can be visualized by about 6 weeks. The viability of the fetus can be assessed by seeing the fetal heart rate and fetal cardiac pulsations from 6 weeks onwards. Assessment of fetal well-being. The use of Doppler ultrasound allows the assessment of velocity of the blood within the fetal and placental vessels and provide indirect assessment of the fetal and placental condition. To detect the malformation of the fetus, what we call is TIFA scan. That we'll do between around 20 weeks of gestation. TIFA means targeted imaging for fetal anomalies. That's called TIFA scan. That is detection of malformations in the fetus. Major structural abnormalities occur in 2 to 3% of pregnancies, and many can be diagnosed by ultrasound scan around or before 20 weeks of gestation. Common examples include spina bifida, neural defects like spina bifida, hydrocephalus, and other skeletal abnormalities such as achondroplasia, abdominal wall defects such as exomphalus and gastrochisis, and facial defects like cleft lip, cleft palate, and congenital cardiac abnormalities can also be detected by ultrasound. First trimester ultrasound. Soft markers for chromosomal abnormalities such as absence of fetal nasal bone and increased fetal nuchal translucency are now in common use to detect features at risk and chromosomal anomalies such as Down syndrome. Once we diagnose any chromosomal anomalies like Down syndrome, etc., we have to terminate the pregnancy. So to take a decision where to terminate the pregnancy or to continue the pregnancy, we have to do the soft markers for chromosomal abnormalities. So you have to see for fetal nasal bone and increased fetal nuchal translucency. Then measurements can be made accurately and gestational age, size and growth can be ascertained. To ascertain the gestational age in early pregnancy, crown rump length CRL is used up to 13 weeks and head circumference, that is HC, from 14 to 20 weeks, and biparietal diameter and femur length can also be used to determine gestational age. The earlier the measurement is made, the more accurate prediction of the CRL accuracy of prediction 5 days will be preferred to a bilateral diameter of 20 weeks. Accuracy prediction will be 7 days. Then gestation age cannot be accurately calculated by ultrasound after 20 weeks. So the earliest assessment of the gestation age is the gold marker to assess the gestation age. Gestation, because of the wider range of normal values, HC and AC, abdominal circumference and S circumference around the mean. So, assessment of gestation age, what we do before 20 weeks, has got better accuracy than after 20 weeks. In addition to abdominal circumference and head circumference, biparietal diameter, and femoral length, when combined in an equation, provide a more accurate estimate of fetal weight. In fetal growth restriction pregnancies, it is helpful in distinguishing between the types of growth restriction. The types of growth restriction mainly are symmetrical and asymmetrical. Asymmetrical growth restriction is more common than symmetrical growth restriction. This is what is crown rump length or CRL. This is the biparietal diameter. We have to take the biparietal diameter at the arrow sign, that means corpus callosum. You are finding arrow sign at that section. You have to take biparietal diameter and femoral length. We can ascertain to assess the fetal gestation rate. In the abdominal circumference, we have to do the scan at the cross section of the abdomen where the stomach is seen. We should not do at the level of the heart or any other umbilical, at the rate of umbilicus, but you must do at the stomach section, level of the stomach. Placental localization, ultrasonic identification of a lower edge of the placenta to exclude or confirm placenta previa as a cause of antepartum hemorrhage is now a part of routine clinical practice. In 20-week scan, it is customary to identify women that have a low-lying placenta. Amniotic fluid volume assessment. Ultrasound can be used to identify both increased and decreased amniotic fluid volumes. When the amniotic fluid is more, we call it as polyhydramnios. When the amniotic fluid is less, we call it as oligohydramnios. The maximum vertical pool is measured after a general survey of the uterine contents. Then measurement of less than 5 centimeters suggests oligohydramnios. And the measurement of greater than 8 centimeters suggests polyhydramnios. So by that we can assess whether amniotic fluid is more or less. Amniotic fluid index is measured by dividing the uterus into 4 quadrants: right upper, left upper, right lower, and left lower. This is the amniotic fluid index is measured by dividing uterus into 4 quadrants. The vertical measurement is taken of the deepest cord-free pool, where when we take the measurement of the amniotic vertical measurement of the amniotic pool, we must see that the cord is not in that pool. So cord-free pool in each quadrant in the results summated. It should be between 10 and 25 centimeters. Value below 10 centimeters indicates reduced volume, and those below 5 indicate oligohydramnios, while values above 25 indicates polyhydramnios. There is a maximum vertical pool you must avoid while taking the measurement. The umbilical cord loose must be avoided. This is placenta, this is the amniotic fluid. Anencephaly or the causes for oligohydramnios are anencephaly or esophageal ectasia will result in an increase in amniotic fluid. Renal agenesis and posterior urethral valves will result in reduced or absent amniotic fluid. That is, reduced means oligohydramnios, absent means anhydramnios. So direct number of fetuses and chorionicity, detect number of fetuses and chorionicity is helpful by ultrasound. It is clinically useful to determine chorionicity early in pregnancy, twins and higher multiple gestations, like twins, triplets, quadruplets, pentuplets, and sextuplets. When there are 6 fetuses, we call it as sextuplets, and when there are 5 fetuses, we call it as pentuplets, and 4 fetuses, we call it as quadruplets, and 3 fetuses, we call it as triplets, and 2 fetuses, we call it as twins. The first time is placenta tissue is seen within the base of the dichorionic membrane, and it has been termed as twin peak or lambda sign. So by that we'll be able to diagnose dichorionic, diamniotic twins. This is a ultrasound scan of twin gestation where the 2 sacs are seen. This is a lambda sign or twin peak sign, where the red mark is given is a twin peak sign, or it is also called lambda sign. Measurement of cervical length is also important in pregnancy. Evidence suspect that approximately 50% of women who deliver before 34 weeks gestation will have a short cervix. The length of the cervix can be assessed using transvaginal scan. We can have a better cervical assessment with transvaginal scan. Coming to the invasive procedures, ultrasound is used to guide invasive diagnostic procedure such as amniocentesis, chorion venous sampling, and fetal reduction, where there are more number of fetuses. We can do fetal reduction. That means if quadruplets are there, there is more chances for getting aborted. So we can reduce the number of fetuses by doing fetal reduction. While doing fetal reduction, we must be very careful to see that the fetus which has to be reduced have an independent placental supply. So to do fetal reduction under ultrasound guidance, we have to inject potassium chloride solution into the fetal heart. then the fetus will die and that will get absorbed and rest of the fetus will grow. While doing fetal reduction, you must be very careful to assess the fetus who has got independent placental supply. This is the amniocentesis. By doing ultrasound guidance, we can do amniocentesis. We do amniocentesis for chromosomal study. Secondly, when there is acute hydramnios, we do amniocentesis to reduce the volume of amniotic fluid, to reduce the distress of the patient with polyhydramnios. Other uses of ultrasonography is also of value in other obstetric conditions such as confirmation of intrauterine death. Whenever we do ultrasound, when the fetal cardiac pulsations are not seen, we'll confirm the intrauterine death. Confirmation of fetal presentation in uncertain cases. Whenever there is polyhydramnios or fatty abdominal wall, we can confirm the fetal presentation by doing ultrasound. Diagnosis of fetal gender can also be done by doing ultrasound. Diagnosis of uterine and pelvic abnormalities during pregnancies, for example, fibromas and ovarian cysts. With pregnancy with ovarian cysts, we can do interventional ultrasound and take out the fluid from the simple serous cyst if it is existing along with pregnancy. Because we can't operate with pregnancy, with advanced pregnancy with ovarian cyst. Then we have to do the interventional ultrasound and take out the fluid from the serous cyst. Then coming to the MR imaging, magnetic resonance imaging, MRI provides multi-planar views, better characterization of amniotic details with anatomic details of, for example, the fetal brain and information for planning the mode of delivery and airway management at birth. The MRI helps in doing this, where we get the image of the fetal brain and information for planning of mode of delivery and airway management is for those conditions. MRI, magnetic resonance imaging, is the best. Coming to the ultrasound in gynecological practice, this in gynecology, Mullerian agencies, that means Rokitansky syndrome, and measurement of ovarian volume, mean ovarian diameter, and the antral follicle count to calculate ovarian reserve and follicular tracking and pelvic masses can be identified by ultrasound. Symptoms suggest of endometrial polyp, detect endometriomas or appearances suggestive endomyosis and endometrial thickness. Ectopic pregnancy can be diagnosed in the miscarriages, that means abortions. So any abortion, either it may be threatened abortion, incomplete abortion, complete abortion, all these miscarriages can be diagnosed by ultrasound. And the gestational trophoblastic disorders, that means molar pregnancy, which shows snowstorm appearance in ultrasound, we can diagnose in the earliest gestational age. post-micturition urine residual estimation in urogynecology. That is, we do ultrasound and see the volume of urine in the bladder, and you ask the patient to void the urine and come, and we can measure the residual urine. So normal empty uterus, there is a uterine lining, there is an endometrial lining, and the thickness of the endometrium also we can measure. Where there is endometrial hyperplasia, we can assess by ultrasound. MRI can detect lesions more than 5 millimeter in size, particularly in deep tissues. Amenorrhea with pituitary adenoma can diagnose endomyosis pre-surgery, endometrial tumors, staging can be done. The CT scan, we can diagnose ovarian tumors, assessment of liver and lymph nodes, we can do. This is the equipment used for CT scan. By X-ray, vital to exclude lung metastasis, histosalpingogram, that is HSG. This histosalpingogram is done to visualize the uterus, any submucous fibroids, we see it as filling defect, and the excretion of the dye what we inject in the uterus through fallopian tubes and the femoral end of the tubes. We can diagnose that the tubes are patent. Both the tubes are patent. So HSC helps in diagnose the patency of the tubes and uterine content. Any submucous fibroids we can diagnose by seeing a filling defect in the X-ray, histosalpingogram. Thirdly, we will be able to detect the missed loop, that is the intrauterine contraceptive device. When the patient comes with a complaint that she is not feeling the threads of the loop, then the more possibilities are, one is it must have perforated the uterus and gone into the peritoneum. Secondly, it must have been displaced into the uterus, or it must have expanded. So by taking an X-ray, we'll be able to know the where the IUCD is. To diagnose whether it is intrauterine or extrauterine, we have to keep an uterine sound, and when it is in contact with the uterine sound, the IUCD, we can diagnose that the IUCD is displaced and retained in the uterus. When it is away from the ultrasound, we can diagnose that it has perforated the uterus and gone into the peritoneum. So thus, we can locate the intrauterine contraceptive device when with missing threads. So there's the advantage of X-ray in gynecology, and that's how we can diagnose the with hysterosalpingogram the tubal patency. This is a picture of the hysterosalpingogram. This is the uterus, these are the fallopian tube with good spill on both sides. So we keep a cannula inside the cervix and we inject radiopaque dye into the uterine cavity, and by serial pictures we can see the spill of dye into the peritoneal cavity through the femoral end of the tube. If there is no obstruction in the fallopian tube, if there is an obstruction, we can't see the spill into the peritoneal cavity. Thank you for the attention. If you have got any doubts, you can raise the questions. Any questions? Thank you.